Now the next is about the malignancies of the genital system, male genital system, and among them the first is about the penile cancer. Now penile cancer is not a very common malignancy, and the spread of that or the incidence epidemiology is it's around 0.4 to 0.6% of all malignancies in the United States and Europe. In the rest of the world, now the distribution is not uniform throughout. It may be more in some areas otherwise. That's what the geographical pattern says. Carcinoma represents 10% of all cancers diagnosed in some parts of Asia, Africa and South America. And penile cancer tends to be a disease of older men. The incidence of penile cancer increases abruptly in men aged 60 years or older and peaks in men aged around 80 years. However, the tumor is not unusual in younger men. One study reports that 22% of the patients with the penile cancer were younger than 40 years and 7% were younger than 30 years. Now, that's the fact. This is all from the different references which have data from a large number of sources. This is from the surveillance data, epidemiology data from the cancer research centers. The incidence is more common in the older age, and as far as in India, incidence of penile cancer in India, where circumcision is uncommon, is around 3.32 per 1 lakh person, compared to the rate in Jewish individuals living in Israel, where the disease prevalence is virtually zero. So because it is directly related to the circumcision done, the incidence, those communities where the circumcision is done at a younger age, the incidence of penile cancer is very low, whereas in those communities where circumcision is not done, comparatively the incidence is higher. India has one of the highest incidence of penile cancer globally, with rates reported as high as 3.32 cases per 1 lakh in some regions, significantly higher than the global average. In urban India, incidence is between 0.7 to 2.3 cases per 1 lakh, whereas in rural India it's around 3 cases per 1 lakh. So there is a slight difference in the urban and rural area also. The other factors which are known about the penile cancer is one is the risk factor, HP virus, human papilloma virus. It's seen in around 60% of the patients. This also is from the different sources of the data. Another of the factor is those who do not use condoms during sexual activity, they have a higher chances of developing penile cancer. This also is one of the issue. The failure to use condoms regularly doubles the risk of penile cancer. The other well-established risk factors are having, mainly the number one is not having undergone circumcision as a neonate in a younger age. Very interestingly, circumcision, if it is done in adult circumcision, offers little or no protection, and no firm evidence indicates that the sperma acts as a carcinogen, although this belief is widely held. Now, in general, the other people believe that the sperma which is sticking over to the glans penis is considered to be a source of irritation, but now there is no definite evidence that the sperma is a cause for the irritation and the tumor, but there is a notion that it could be one of the issues. Those who have phimosis, they have a high chance of developing the penile cancer. Any chronic inflammation, so starting with some other inflammatory disorder, may result in the penile cancer later. Among them, human papilloma virus is one of the issues. Human papilloma virus, which may present with the genital herpes in the beginning, later on it may result in malignancy. There are many pre-malignant conditions. I will discuss about those pre-malignant conditions somewhat in detail, because from the clinical point of view that's important. The other factors are poor penile hygiene. The maintenance of the hygiene is not proper, and those who use tobacco also have high incidence of penile cancer, and those who are on immunosuppressive therapy for some or other reason also have a high chance of penile cancer. The most common type of the penile cancer is a squamous cell carcinoma, and it's a common type as such, and it almost the course is something like that of the squamous cell carcinoma in the other parts of the skin. That's a relatively slow growing cancer in the early stages. but later it becomes more severe. And quite characteristically, almost 90% of the patients would not have any problem with the erectile function or other sexual functions or voiding of the urine. And even the pain and also is less common in patients as such. And it may be presented anywhere in the penis, but most are found on the glands or prepuce over the tip. It can occur anywhere. The other common clinical presentation is the most common clinical presentation is a sensation of itching or burning under the foreskin, or an ulceration in the glands are the most common presenting symptoms. Pain is rarely present in patients of penile carcinoma. Now, because of this, the patients usually report much later. They do not come in the early stages. One is, as such, the penis is considered to be a private organ, and the patients would have a hesitation to show it to the doctor. And the other is the symptoms are very mild. The other common clinical symptoms which may occur could be ulcerated growth or a nodular growth. A nodule like swelling may occur, and there could be foul smelling discharge, itching, pain is rare, inability to retract the prepuce, that's phimosis occurring in the later stages. Difficulty in micturition is a very rare phenomenon. Whitish patch on the penis is very typical in case of a leukoplakia resulting in the carcinoma. And one of the common presentation which we see in our setup, because the patients come at a later stage, is swelling in the inguinal region. Patients may present with swelling in the inguinal region, which is looking like a lymph node enlargement. And when there is a inguinal lymph node enlargement, particularly external inguinal group of the lymph nodes are enlarged, it's quite important that you examine the genital organs as well as the rectum, because there could be the primary in these areas and the secondaries could occur and should not be missed. That's one of the issues. Bleeding from the growth or paraphimosis also could be a presentation, or systemic symptoms like loss of appetite and loss of appetite, weight and appetite also could be the lesions. Histologically, there is a practice of grading this into low grade and high grade. Low grade lesions are which are having a relatively slow course and have a somewhat better prognosis, whereas the high grade one are poorly differentiated and they may show a growth which is rapid as such, and microscopically it can see that there may be a hyperchromatic nuclei. The nuclei may have more stain in high grade lesions, and they also tend to metastasize rapidly, whereas low grade lesions would show a keratin tissue in the tissue, these cells seen, and about 70 to 80% of the cases are of low grade variety. Quite important is to identify the patients in pre-malignant conditions. As I told you earlier, the common pre-malignant conditions which we see in the genital organs male would be the intraepithelial neoplasia, penile intraepithelial neoplasia, which is often seen as a flat red colored patch with the irregular or poorly defined margin in the glans penis. Only when you palpate, you may feel that there is a slight induration, but not very much, and the skin may show slightly whitish color. That's the typical of intraepithelial neoplasia, and this is considered one of the pre-malignant condition. And at that stage, if you have diagnosed, the treatment would be comparatively easier. A penis conserving treatment is possible, and a good number of patients in that stage would respond very well to our treatment like Kanchanara Gukulu, and I have treated a few of the patients at that stage, and they have not progressed further in. The other part is about maintenance of the hygiene of the penis. Then another of the pre-malignant condition is Bowen disease, and usually Bowen's disease is seen as a circular lesion and raised surface. In these conditions, usually in the distal shaft of the penis, and this has to be always, biopsy has to be done in this condition, and a painless ulcer over there. Then Bovenard papillosis, that multiple papillae-like lesions could be seen, which are looking like genital warts, so in the shaft of the skin or in the penis, and they may have a different presentation, either maculopapular lesions or erythematous lesions, soft as such, pigmented, which also can be a premalignant condition. Then another of the type of the lesion which is not so common is a giant condyloma or Busch-Lowenstein tumor, where there would be a huge mass of keratinized tissue. It's a cauliflower-like mass in the genital area, or even it can occur in the anorectal area. And these are benign lesions, not malignant, and simple local excision would be enough in these conditions. And histopathologically, it will prove that it is a benign lesion as such. Many times, the local application of irritant substances also could be a cause for this condyloma. Then another is the cutaneous penile horn, which is actually a consequence of a previous injury, abrasions, or particularly those who have some scar marks earlier, and which may result in epithelial cornification. Epithelium becomes corn-like, which looks like a hardened projection over the area, and this also leads to suspicion of malignancy, but it is not malignant. It's a pre-malignant condition which can, in due course of time, may result in malignancy. Then erythroplasia of choroid is a well-demarcated area over the glands or the foreskin with red and velvety appearance, smooth, shining appearance is seen, and that's called erythroplasia. Similarly, leukoplakia as in case of the mouth, here also there could be whitish patches, which is often associated with the chronic irritation, chronic inflammation as such, and often seen in patients of diabetes. See, patients of diabetes, they often tend to have balanitis or balanopostritis, very common. And in those patients, once you have cleaned the smegma, see, in the patients of diabetes, when the patient would have balanitis, usually the foreskin would have some cracks, and then a lot of discharges or secretions could be sticking to the area. Once you have cleaned those areas, if the glans penis skin shows this surface irregularity, whitish, permanently whitish color, then it is considered as a leukoplakia. Very often it is seen in patients of diabetes, and one of the common features of diabetes patients. Now, and most of these conditions, they do not require a specific treatment unless if you have managed diabetes mellitus, they respond well, and usually they do not become malignant. This is what I have observed. So, a leukoplakia in the penis, though it is considered as a precancerous, a careful maintenance of the diabetes in such patients often can result in a rather almost total recovery. Then another of the condition is lichen sclerosis or Berenice xerotica, where there could be a thickening of the skin, foreskin, and whitish color and cracks, which also can be seen in case of diabetes patients as such, which is considered to be a pre-malignant condition, and most of the times it ends up in circumcision. Now these patients, because the glands, the prepuce cannot be pulled back, it results in a phimosis. Circumcision is done, but circumcision done in such patients, you will have to send the tissue for histopathology and confirm that there is a malignant lesion or not. A confirmed diagnosis, it would be a sclerosis, lichen sclerosis, could be resulting in a thick, very thick, and palpate, when you palpate it, you can feel the difference. The foreskin becomes very thick, hard as such, and the consistency will be hard. That also is a confirmed diagnosis. When there is a typical huge ulcer, fragile ulcer, and with the projecting surface over the area, that confirms the papillary carcinoma. Similarly, squamous cell carcinoma can be presented as a foul smelling and necrosed tissue, irregular surface with erosion of the penis, like a penile structure could be eroded. Verrucous carcinoma often presents with the fungating lesions, rough keratinized lesions which are seen along with the erosion of the penis, and that confirms the diagnosis. So, in majority of the cases, the diagnosis is based upon the clinical examination than any investigation. So, penile carcinoma, when a patient presents with the symptoms in the penis, it's quite important that you have a thorough clinical examination, palpate the lesion, and then make the diagnosis, then really depending on any investigations. As far as the staging of this penile carcinoma is concerned, there is no universal specific staging system. The usual TNM staging is adopted. There is a method of classifying the penile carcinoma into stage 1, 2, 3, 4 depending upon the extent of the lesion. If the tumor is confined to the glans or prepuce or both, stage 1A, and stage 2 is the tumor extends into the shaft of the penis, and if the tumor has a inguinal metastasis that is operable, stage 3. Tumor involves adjacent structures along with the inoperable inguinal metastasis and distant metastasis, that's the stage 4 as such. And the whole approach would be in a patient who have inguinal lymph node examination. The risk is predicted based upon the inguinal node examination or involvement of the inguinal node, as well as the histopathological appearances. And it's after a thorough clinical examination of the inguinal lymph nodes and with the specification of this histopathological picture, the risk is predicted into 3 categories: low risk patients, and the low risk patients where the histologically grade 1 is there, the approach would be there should be surveillance rather than this inguinal lymph node dissection. There is no need of lymph node dissection. You have to observe, see if the lymph nodes are enlarged. Only if the lymph nodes are enlarged, then you go for the lymph node dissection. Otherwise, local hygiene is maintainable. In a large number of patients whom we see with the penile cancer, they are of the low risk category, and they can be managed with the local hygiene and a continuous observation. Intermediate risk patients are where there is a node, single node, and almost confirmed diagnosis of inguinal penile cancer. They require a surgical approach of lymph node dissection. Then high risk patients, that the patient would have evidence of extension as such, and in such conditions the patient may require all your protocol of the treatment, and it may require the investigations like CT, MRI to confirm the diagnosis. And the treatment, the protocol treatment as such would be, of course, the standard protocol of the treatment is amputation of the penis, either partial or complete. But these days there is a tendency to go for penis conserving approach. So earlier, most of the patients whom we could treat with the partial amputation. Partial amputation is a relatively easy, simple procedure where the urethra is saved, and the corpus spongios, they are removed as such. They are removed partially, and it's a relatively easy surgery. But because it produces a lot of emotional burden, these days there is a approach or a tendency to have penile conserving approach, and one of the options which are tried is local excision with or without circumcision. Circumcision with the simple local excision of the tumor, preserving the penis is also one of the approach wherever it is possible. Then the other approaches which are becoming now popular are laser therapy or photodynamic therapy for superficial lesion, or micrographic surgery for verrucous carcinoma. Then the partial amputation is when it is involving glans and distal shaft as such. Intraepithelial neoplasms such as bovine disease or erythroplasia may be treated with the topical application of fluorouracil. Now that's what the modern science say. But I would say is there is no need of topical application. Just keep it clean and dry. Maximum it can be washed with Teflon. With that, many of these conditions can be managed. Radiation therapy used as an alternative in selected patients as such. Prognosis of penile cancer is primarily related to presence or absence of the inguinal node metastasis. Untreated patients with inguinal metastasis rarely survive 2 years. And of those with the clinically palpable adenopathy and histologically proven metastasis, 20 to 50% are alive at 5 years following inguinal lymphadenectomy. So surgery has a definite advantage in prolonging life of the patient as per the data. So that's about penile cancer. The next is we will discuss about the tumor of the testes, tumors of the testes. Tumors of the testes are classified based upon the origin of the tissue, and WHO 2022 classification says the types as 2 categories: germ cell tumors and sex cord stromal tumors, depending upon the origin of the cell. And the 90% of the patients are the germ cell tumors, And there again, the germ cell tumors are again classified further into those cells which are derived from the germ cell neoplasia in situ. Initially, the germ cell would be having that malignant lesion, and it's again categorized as seminoma or non-seminoma or mixed germ cell tumor. And there again, based upon the type of the tissue, it is categorized as embryonal carcinoma or yolk cell tumor or teratoma, which is post-pubertal type, or trophoblastic tumors based upon what you see under the microscope. And these classifications, they have a significance only in planning the approach to the treatment. Clinical presentation will be almost similar. And unrelated to germ cell neoplasia in situ are spermatocytic tumor or yolk sac tumor or teratoma or testicular. The other 5% are the sex cord stromal tumors, which are leading tumors, sertoli tumors, granulosa cell tumors or fibroma. What I mean by this, I will show you that when I say the typical origin of the tissues from the testis, the testicle structure would have the epididymis, then the retate testis, the folds, which will have that germinal cells, and that type of the cells would be that seminiferous tubules would have that sperm producing cells, which are the Leydig cells, which are in the periphery, Sertoli cells which help in secretion of the hormones as such, and the spermatogonium is the base structure which produces the sperms, and then you have the spermatozoa seen there. Now, based upon type of the cell seen under the microscope, when you see a type of circular arrangement in the growth area with a central structure that's called as Schiller dual bodies, then the histopathologist would give you a opinion that it is a yolk cell tumor. If the structure shows islands of such tumor cells with a central vessel in the middle, then the diagnosis is embryonal carcinoma. A choriocarcinoma is a haphazardly arranged cells which are having larger nuclear body, cytotrophoblast, or those which have larger protoplasm area, syncytoblast cells, that's considered as a choriocarcinoma. Seminoma is when the semen producing cells which have more of lymphocytes and fibrous tissues in them, then it's considered as a seminoma. Or Leydig cell tumors are when there is a basic stain in structures with some crystallized substances which are called as Rinker crystals, then it's a Leydig cell carcinoma. Or Sertoli cell carcinoma, where the cells resemble that of the Sertoli cells and they are presented as some nodular structure in the middle under the microscope. So this classification is mainly based upon the histopathological classification than really the clinical as such. The incidence of testicular cancer is a most common solid cancer in men aged between 15 to 35. It's one of the diseases of the younger age. And incidence rates are highest in the Western Europe, North America and Australia, and it's lowest in Asia and Africa. In India, compared to the global incidence, the incidence is lesser. And incidence rates have been increasing globally even in areas with the historically low rates. Now, there is a tendency to have increased cancer as such. Testicular cancer can occur at any age, but is most common between the age of 15 to 35 years. About 50% of the cases occur in between men between 20 to 34 years old, and there is a secondary peak. The incidence also rises at the age of 60. So that's a very typical presentation, and because it involves majority of the younger patients, it's an issue of concern. As well as the known factors about the etiological factors, genetic factors have a role in the development of testicular cancer, and it's shown by the fact that risk of the disease is higher in first degree relatives of cancer patients than in general population. About 2% of the testicular cancer patients report having an affected relative. Siblings are at particularly increased risk. That's if one person has a cancer, his brothers would have a high risk of around 8 to 10 times more than others. If a father has a tumor pathology, the testicular tumor, son has a risk of around 4 to 6 times more than the general population as such. The other known causes, which are well known causes, are patients who have a cryptorchidism, that's undescended testicle, have a 2 to 4 fold increase in the risk. And cryptorchidism is more common on the right side, and hence in general right sided testicular cancer is more common also. That's also true. The issue is the undescended testicle, if it remains in the remains undescended for age of more than 5 years, it has a high chance of developing into neoplastic condition. The reason is in the testicles, when it's in the scrotum, the testicles temperature is regulated by the dartos muscle contractions. The dartos muscle helps in maintaining the temperature of the testicles properly, less than that of the core body temperature for normal function. But when it is in ectopic, when it is not in the normal position, that temperature regulation is not there, and hence the cells have a tendency to change into malignant condition. Family history is also one of the factors, and I think we have already discussed, like increased risk of 6 to 10 fold in brothers or sons affected by these testicular tumors. The other known factors are infections with the human papillomavirus or Epstein-Barr virus or cytomegalovirus or parvovirus B19 or HIV. The incidence of testicular cancer has increased. Testicular trauma, previous trauma also can be a cause for the testicular cancer. Persons who have high estrogen level, maternal estrogen levels, also have a high risk of developing cancer, testicular cancer. Maternal estrogen levels could be increased either as a result of the abnormal hormonal cycles, or at times it could be induced due to some drugs also. In patients with the localized disease, the clinical presentation is often it's a painless swelling or a nodule in one of the testicles. Is the most common presenting sign, and the nodule cannot be separated from the testicles. When you palpate a nodular swelling, the commonest type of the nodular swelling which we see in the clinical practice is the swollen epidermis. That epidermis would be painful, and it will be always present on the tip of the testicle, and it can be freely separated, or you can feel that gap between the epidermis and the testicle, and often it will be tender, moderately tender or severely tender, depending upon the stage in which you have seen the patients. But a testicular tumor may be presented as a nodule which is non-tender, and it could be anywhere in the testicle, and it cannot be separated from the testicular body. So careful palpation is one of the most important method of confirming the diagnosis of testicular tumor. And the patients who had a atrophic testis earlier, if they feel that the testicles are increasing in size, the atrophy of the testicle could occur due to many reasons, congenital or otherwise. If it is shows a sign of increasing in size, then there is a cause of concern, and that has to be examined as a possible changes of neoplastic condition. A dull ache or heavy sensation in the lower abdomen could also be a presenting symptom in some of the patients. So patients presenting with the vague, undiagnosed abdominal pain, you have to examine the genital organs, see if that could be a possible cause as such. Previous trauma like hematoma or trauma should also undergo evaluation for the testicular cancer. Usually, depending upon the type of the cancer and the age-wise incidence would be in the first decade, that's 1 to 10 years, it could be either testicular teratoma or yolk sac tumor. In the second decade, that's 10 to 20 years, it could be choriocarcinoma. Third decade, that's 20 to 30, embryonal cell carcinoma. Fourth decade, seminoma, and 70 years above, it's the lymphoma or non-Hodgkin's lymphoma, rarely spermatocytic seminoma. See, majority of the patients whom we see are at the age of that 40 plus beyond that, or old age patients, and they are seminoma patients. Incidence of these in the first age, 10 years to 20 years, is very low, and comparatively these tumors, yolk sac tumors and testicular teratoma, choriocarcinoma, they have a high chance of malignancy or rapid growing tumors, whereas seminoma are comparatively slow growing tumors. Now, patients with the disseminated clinical presentation also can be related to the stage in which the patient is presented. A good number of patients may be presented in the late stages where the lesion has spread beyond, and it may be spreading through the lymphatic or hematogenous spread. When it is through the lymphatic stream, the lymph nodes enlarged could be presented, and very commonly the supraclavicular lymph nodes are enlarged. As in case of any visceral malignancy, the supraclavicular lymph nodes could be presented. So, patient presenting with the supraclavicular lymph node enlarged, you have to examine the abdomen first. The stomach could be one of the sources. Then the next is the testicles, which have to be examined to rule out the possible site of the primary. And metastatic disease also can present with the anorexia, nausea or gastrointestinal symptoms. A huge retroperitoneal lymph node can present with the back pain, cough, chest pain, hemoptysis or shortness of breath, also be sign of lung metastasis. These are the common sites where the metastasis would occur. Central nervous system disease of localized lesions rarely may occur in testicular cancer. Gynecomastia may also be seen in about 5% of the patients with the testicular germ cell tumors, and usually in younger age, and that because they produce a lot of human chorionic gonadotropin. Or overproduction of HCG also can result in hyperthyroidism features. Important is one thing which is important is any solid firm mass within the testis should be considered testicular cancer until proven otherwise. This is one of the important criteria. So, if there is a testicular mass which is firm, then till it's proved otherwise, you have to consider that as a possible malignancy. Staging of the testicular tumor is based upon the extent of the invasion of the tumor, and it's categorized as a PT1, PT in situ or PT1, PT2 depending upon the extent of the lesion. And this diagram shows like exactly PT1 is when the testis and epidermis without lymphovascular invasion, is limited to that. PT2 is testis and epidermis with the lymphovascular invasion, and tunica vaginalis also is involved. PT3 is it invades the spermatic cord acid, and PT4 is it invades the scrotum, it has reached up to the scrotal wall. And PNT is when the lymph nodes are enlarged and within mass is in between 2 cm to less than positive 5 cm. Lymph nodes mass is more than 2.5 cm or more than 5 centimeters as such, then it's PT2, and this way you go up to the PT present as such, PN or M1 metastasis also. The other way is based upon the hormonal assessment. If the LDH level is higher, then it's categorized as S1, or HCG level or AFP levels are within normal limits, S1. If they are increased, then it's S2. This is how it's diagnosed, staged as such. The most important, crucial investigation to confirm the tumor is ultrasound. Ultrasound plays a significant role in diagnosing the primary tumor of the testicle. A carefully done ultrasonography would not miss the diagnosis. Chest radiography or CT or PET scan may be used at different stages to confirm whether there is a secondary or not. Rarely they may help in diagnosing initial diagnosis. Initial diagnosis is always based upon the ultrasonography. Rarely the CT could be used as a primary diagnosing tool. MRI serves in as a problem solving tool. In the initial diagnosis, if there is a CT doesn't confirm this way or that way, MRI can help. Ultrasonographic picture would be seen with that irregular density of the tissues seen, as you see in this image. You see that irregular density of these images within the testicular area, or increased vascularity when the Doppler study is done. CT and MRI will show you the typical lesion and its extension, like extension, whether it is beyond the area or whether it has reached to the tunica vaginalis or not. The other is tumor markers. The tumor markers like AFP or HCG or LDH. These also are used in the diagnosis of tumors, and particularly AFP is in non-seminomas, younger age patients, and HCG is again more common with the non-seminomas, sometimes in seminomas also, but lactate dehydrogenase is associated with seminomas. Patients with the older age, LDH would be the method of confirmation of the diagnosis or helping in making the diagnosis, whereas younger age AFP is the better choice. Treatment, particularly architectomy is the treatment. It is the main treatment of the testicular cancer, along with the retroperitoneal node dissection if there is a necessity. Chemotherapy, the options which are now tried are combination of bleomycin, etoposide and cisplatin, or a combination of etoposide and cisplatin. These are the options as such. The current guidelines would be the latest guidelines, where the surgery is and chemotherapy role is more defined, and by the Cancer Network Institute. This guideline was released in 2022. If it is a seminoma stage 1 or a 1B, architectomy alone and no follow-up treatment, or occasionally adjuvant therapy, no need of chemotherapy. Now, this is one of the important issues. The patients who come to us, we can manage with the architectomy alone, and there is no need of chemotherapy if they are seen in the early stage. And if there is a stage 1S, then architectomy and follow with the tumor marker to see whether there is a recurrence or not. If it is stage 2A, architectomy and chemotherapy, and stage 1C, chemotherapy and radiation, then surgery if necessary. Non-seminoma stage 1AB, 1 are in situ conditions. Chemotherapy, radiation and radical architectomy is study done as such. And non-seminoma stage 2A and 2B, radical architectomy. Radical architectomy involves complete removal of the testicles as well as the lymph nodes, retroperitoneal lymph node excision and chemotherapy. And if the patient has a non-seminoma stage 2C or beyond, or brain metastasis, 20 to 30% of the patients with metastatic testicular cancer cannot be cured with the chemotherapy, but the chemotherapy is only one choice by which you can pull out with the patient. Recurrent disease, it's only the salvage treatment. There is no option of curing that. As per the data prognosis, according to SEER data from 2013 to 2019, overall 5-year survival is 95.2%. It's a quite high survival period. So prognosis varies somewhat depending on the histological type of the cancer, seminoma and non-seminoma stage, and other features such as tumor marker and type of metastatic disease. By stage, 5-year relative survival period is 99.2% for patients with the localized testicular cancer, and 96% for patients with the cancer that has spread to the regional lymph nodes, and 73.4% for patients with the distant metastatic disease, and 91.3% for unstaged disease. That's about the testicular cancer. With this, we will conclude today. Next, we will take up prostatic cancer in the coming session. If there are any questions, right. Multipara women will increase incidence of testicle. That's whether twin pregnancies both these factors are not proved. See, multipara women as well as twin pregnancy having chances of testicular cancer is not proved anywhere. Right. Okay.